I would like to thank SAGE's leadership and its members for the opportunity to present SIMPL, Zwisch, Can Performance Measurement Technology Enhance Autonomy in the Operating Room? I'm Dr. Erica Sutton, Associate Professor of Surgery and Associate Dean for Academic Programs and Affiliations at Morehouse School of Medicine in Atlanta, Georgia. I have no disclosures relevant to the subject matter of this presentation. As a result of this activity, participants will be able to engage in discussion about resident readiness to enter independent practice, recognize the components of the Zwisch scale and SIMPL assessment, and analyze strategies to enhance resident autonomy using performance measurement technology. In 2013, Matar and colleagues from 14 academic institutions published the results of a global assessment survey sent to all subspecialty program directors of minimally invasive surgery, bariatric, colorectal, hepatobiliary, and thoracic specialties. There were 46 quantitative questions distributed across 5 domains. Of the 145 program directors receiving the survey, 91 returned responses for a 63% response rate. Of respondent program directors, 21% felt that new fellows arrived unprepared for the operating room. 38% demonstrated lack of patient ownership. 30% could not independently perform a lap chole, and 2/3 were deemed unable to operate for 30 minutes unsupervised of a major procedure. With regard to laparoscopic skills, 30% of new fellows could not atraumatically manipulate tissue, 26% could not recognize anatomic planes, and 56% could not suture. Furthermore, 28% of fellows were not familiar with therapeutic options, and a quarter were unable to recognize early signs of complications. Finally, it was felt that the majority of new fellows were unable to conceive, design, and conduct research or academic projects. These findings gave measure to a growing concern that general surgery training was not enough to prepare surgeons for safe, independent practice, and that fellowship training pursued by 80% of general surgery graduates was de facto obligatory. The surgery community began then to rightly focus its attention away from who is responsible to how do we improve this. Later that year, Dr. Mary Klingon-Smith wrote, "To address the issues effectively, greater recognition and engagement are needed by the surgical community so that effective solutions can be crafted. These will need to include improvements in the efficiency of teaching with the assumption of greater individual resident responsibility for their knowledge, the establishment of more defined standards for knowledge and skills acquisition by level of residency training, with flexible self-assessment available online, greater focus of the curriculum on current rather than historical practice, and increased use of structured assessments and modifications to the overall structure of the traditional 5-year residency." That work in structured assessments is the subject of our inquiry here. In 2014, the Zwisch scale for resident autonomy was validated. The Zwisch scale is a 4-level scale with gradations of resident autonomy from 1, show and tell, to 2, active help, 3, passive help, and 4, supervision only. Levels 3 and 4 are considered meaningful autonomy. In addition to the Zwisch scale, as part of validation, raters were also asked to rank the complexity of the procedure for which they were completing an evaluation. Was the procedure among the easiest third, of average complexity, or the hardest 1/3 of procedures they have completed in their experience? Validation of this scale proved that resident autonomy could be measured and tracked via a smartphone application. The following year, and from this work, the Procedural Learning and Safety Collaborative was established in January of 2015. The PLSC led the development and launch of SIMPL, a system for improving and measuring procedural learning, an evaluation system that uses the 4-level Zwisch scale and complexity ranking in a smartphone app to collect evaluation data on both residents and faculty. As part of their introductory statements, the PLSC stated a general surgery residency should not function as middle school, expecting additional experience through fellowships to complete the training. That same year, a central endorsement was given by the American Board of Surgery when the ABS agreed to fund a multi-institutional research study to test the SIMPL application as a real-time assessment tool for intraoperative performance of general surgery residents. The PLSC was able to recruit a total of 14 programs across the United States to participate, and the data collection phase of the trial concluded in December of 2016. Let's talk briefly about the SIMPL tool itself. The SIMPL system offers an approach for documenting readiness for independent practice by 1. Determining the extent of autonomy each resident and groups of residents achieve by procedure. This is accomplished with the 4-level Zwisch assessment, providing feedback to residents on what they need to accomplish to earn the next level of autonomy for a given procedure. This is accomplished in the narrative portion of the app. Clinical rotation planning, so the exposure to procedures and duration increase the likelihood that residents will achieve the level of autonomy desired for selected operations. This is accomplished with programmatic review of SIMPL data, as is identifying attendings who may need faculty development to learn how to more effectively teach in the operating room. Again, these two are not inherent to the app, but require program-level review of data. And finally, as collated across programs, SIMPL can help determine the average number of cases needed to achieve autonomy. Let's look at the results of the validation. 368 attending surgeons rated 393 categorical residents after 5,861 procedures. The 5 most frequently rated core procedures were lap chole, lap appy, open inguinal hernia repair, open ventral hernia repair, and exploratory laparotomy. For the most frequently rated procedure for residents in their final 6 months of training, lap chole, the proportion of performance ratings at practice ready or exceptional was 87%. The graph on the right shows that for the 5 most frequently rated core procedures performed by residents in the last 6 months of training, the proportion of Zwisch ratings indicating near independence, supervision only, was just below 50% at 49.1%. The authors concluded that U.S. general surgery residents are generally, but not universally, ready to independently perform the most common core procedures by the time they complete residency training. Resident autonomy is limited, and it is unknown if the amount of autonomy residents do achieve is sufficient to ensure readiness for independent practice. So let's now look at what has worked to enhance resident autonomy to answer the question if these performance measurement technology trackers can improve that performance, that autonomy. Sheeman and colleagues recorded 958 global rating scale of operative performance evaluations by 32 general and subspecialty faculty surgeons for 35 residents. A wide range of elective procedures were evaluated. Each resident was scored from 1 to 5, 1 being the lowest, 5 being the highest, in each of the above categories of the global rating scale of operative performance. Resident operative autonomy was assessed using the Zwisch scale. Results indicated a positive correlation between resident autonomy and measures of operative performance. The significant predictors of autonomy were time and motion, flow of operation, and residents' preparation for the procedure. The authors concluded that resident operative autonomy is a product of shared responsibility between the faculty and the resident. However, resident skills and preparation for the procedure play a critical role. Residents should be advised to use available resources such as simulation to augment their skills preoperatively and to enhance their autonomy in the operating room. Subsequently, Williams and colleagues performed a study in which they concluded that resident operative performance quality is the most important determinant in attending surgeon decisions regarding resident autonomy. They conducted 8,798 assessments collected from 429 unique surgeons assessing 496 unique residents. Practice-ready and exceptional performances were 20 times more likely to be performed under meaningfully autonomous conditions than were other performances. Meaningful autonomy occurred most often with high volume, easy, and common cases, and less complex procedures. 10 surgeons failed to afford residents meaningful autonomy on any occasion. This is important as we talk next about how SIMPL and Zwisch can be used to provide data on faculty behaviors. In 2015 to 2016, Zandu and colleagues looked at entrustability as a function of faculty behavior using OpTrust, a validated tool designed to assess progressive entrustment in the operating room. Researchers observed surgical intraoperative interactions between faculty and residents in 117 cases involving 28 faculty and 35 residents, and rated entrustment behaviors. Without intervening in the interaction, 1 or 2 researchers observed each case and noted behaviors, verbal and nonverbal communication and interaction processes. Immediately after the case, the assessment was completed. Observer results were compared with resident and faculty-reported entrustability measures following a 4-point scale. Difficulty of operation was rated on a scale of 1 to 3. This is to point out its similarity to the Zwisch scale. Analysis showed that faculty entrustment behaviors were significantly associated with resident entrustability. The authors concluded that faculty entrustment behaviors may be the primary drivers of resident entrustability, and further suggested that faculty entrustment is a feature of faculty surgeons' teaching style and could be amenable to faculty development efforts. I've added that familiarity also leads to entrustment behaviors by faculty. The same group published subsequently that surgeons who feel highly familiar with the resident are more likely to entrust that resident and give them more autonomy in the operating room. This is an important distinction because familiarity identifies both formal and informal ways in which faculty and residents know each other and can denote or be influenced by surgical culture. The authors identified 6 themes as influencing progressive entrustment in the operating room: optimizing faculty intraoperative feedback, policies and regulations affecting the role of the resident, flexible faculty teaching strategies, context-specific variables, leadership opportunities for resident in the case, and safe struggle for residents when appropriate. Perspectives of faculty and residents, while overlapping, were different in their emphasis. Better understanding of faculty-resident interactions, individual behavior, contextual influences, and national regulations that influence intraoperative education have the potential to significantly affect progressive entrustment in training programs. In conclusion, resident autonomy is enhanced by performance measurement technology because of its ability to provide feedback on resident operative performance and faculty teaching behaviors. It has the potential to improve resident autonomy via correlational data on case volume specific to procedure or training program, though this has not extensively been described to date. Thank you again for the honor of the podium.